Hello students, I am Dr. Saurabh Srivastava, reader in the Department of Oral Medicine and Radiology, PPT College of Dental Sciences, Lucknow. Today we will be discussing about the antibiotics which are used in dentistry. In part 1, we will take up the introduction of the topic, classifications involved, routes of drug administration, dosage principles, duration of the antibiotic therapy which is required, effectiveness of those antibiotics, and indications of the antibiotics. So let us take it one by one. To introduce the topic, we would say that antibiotics are chemical substances which are produced by the microorganisms, mainly the fungi, actinomycetes, bacteria, that suppress the growth of other microorganisms and may eventually destroy them. The purpose of this antibiotic therapy is to aid the host defenses in controlling and eliminating the microbes that are temporarily have overwhelmed the protective host mechanism. That means temporarily the microorganisms they have taken over the host mechanisms. The volume of the distribution and hepatic and renal excretion ratios they constitute major determinant of a drug's half-life, which is the time required for the peak concentration of the drug to fall by 1/2 in a given body fluid. The determinants of the clinical outcome of the antimicrobial therapy they include nature and virulence of the offending organism, site of infection, possibility of establishing a surgical drainage, ability of the antibiotic to penetrate to that site, post-antibiotic effects, and the adverse drug reactions which are involved, and also the efficiency of the host defenses. They will all be determining the outcome of the process. Now, chemotherapy is also a word which has been used, and it says that it is the use of chemical compounds in the treatment of infections so as to destroy the offending organism or the parasites without damaging the host tissues. Now, a chemotherapeutic agent, it may be either bactericidal or bacteriostatic. You all know this thing. And the drugs which are used as therapeutic agents, they will target 4 common sites in the bacteria. First is the cell wall. Another inside the cell wall is the cytoplasmic membrane or the cell membrane. Then within the cytoplasm, we have the ribosomes and the RNA molecules which are involved in the transcription of the genetic information. All these things can be targeted by the drugs. Now, there have been various classifications which have been given for antibiotics, and you have studied them in your pharmacology lectures. These classifications have been based on the chemical structure, mechanism of action, the type of organism against which it is primarily active, spectrum of the activity of the drug, the type of action, what action the drug has, and the antibiotics from which they are obtained, and the organisms which are susceptible to it. Then we will come to the routes of drug administration. Before that, we have completed the classification part and we come to the routes of drug administration. As you know that the route of drug administration is very important in the uptake of the medicine. So, antimicrobial drugs can be administered either locally or topically. Orally, that they can be given. They can be given parenterally, which can be intramuscular or intravenous injections. They can also be given as intralesional injections, as we do in the skin or mucosal diseases. The absorption of this drug which is given orally, it is decreased in the presence of food. So, whenever we are giving the drugs orally, they should be given not within the time period when the food is being taken. That means they have to be given not less than 1 hour before or at least 2 hours after meals. And many a times the food which we take, it interacts with the antibiotics, like the tetracycline, it is interacting with calcium containing compounds like milk. Antacids, they interact with metallic cations or iron containing salts. So we have to be careful about this thing also. Then coming to the dosage principle, what dose should be given to the patients? Now, giving the dosage of the antibiotics depends upon the severity of the infection. So there have been various dosages which have been advised, first being the vigorous dosing. Now, vigorous dosing means giving the antibiotic in very frequent doses. That means if we want the infection to be cleaned up quickly, we want the antimicrobial agent to be given frequently. The current trend is also saying that the antimicrobial agent can be given for a short time as a vigorous dose, depending upon the clinical situation. So, whenever dosing is judged or it is given, it has to be based upon the clinical judgment of the clinician. Now, high concentrations are more critical with some drugs like aminoglycosides, metronodazoles, quinolones, where prolonged exposure of the organism to the antimicrobial agent is more critical. Now, in cases of beta-lactams, the time-dependent antibiotics have to be given. Now, the loading dose says that before giving the antibiotics or when we start the antibiotics, we have to give a higher dose, which will make the antibiotic reach maximum therapeutic blood and the tissue levels when we are giving orally. So a loading dose will give that achievement quickly. Otherwise, it will take 6 to 12 hours to reach that maximum therapeutic blood levels. Then maximum blood levels, what are the maximum blood levels? Now, to achieve those blood levels, at least 2 to 8 times, it has to be the minimal inhibitory concentration, MIC, where such blood levels are necessary to compensate for the tissue barriers which will restrict the antibiotic penetration to the site of infection. Now, using frequent dosing intervals. Now, the dosing intervals which are there, it is important that some penicillins, they need very frequent dosing as they are disintegrated into the blood and does not reach the constant blood levels so easily. So they have to be given very frequently, which is not nowadays they are not used commonly. Then to determine the duration of the therapy by remission of the disease. Now, determining that duration, we have to give the therapy, we have to wait for the remission and then stop the therapy after some time when the infection has resolved. The principle of dosing also says that sometimes their improper dosing may be done. It may be done in the form of inadequate concentration of the drug when it is achieved, then inadequate duration of the therapy if the clinical judgment does not allow us to be so adequate. So we may give duration of the drug to be smaller. Then excessive dosage when it is given, it may lead to toxic effects also to the host. Then coming to the duration of the therapy, how we will determine the duration, it is also very important when determining the duration of the therapy. There is a concept that we have to give the therapy for this much time or this much time. Is there any course of the therapy in antibiotics? We have heard about it, but is it there? Ideally. So we have to think over it. There is a conceptual error, I think, regarding the course of the therapy. It can be due to several faulty assumptions which are there. Now, as the remission and relapse of the infection is possible with the therapies, now most of the times it is said that it should be given till the time of remission and after that also. According to Nosby, the ideal duration of the antibiotic therapy is the shortest that will prevent both the clinical and the microbiological relapse. So the clinical relapse should not be there and the microorganism should also be eliminated from the host body. That should be the duration of the therapy. Rebound infection is also many times possible where in the antibiotic therapy is unnecessarily prolonged. But in oral infections, rebound therapy is not rebound infection is not a possibility, because in orofacial infections, if we remove the source of that infection or the nidus of infection, then rebound infection is not going to happen. In case of resistant microorganisms, many times it is thought that if the infection is due to some resistant microorganism, the antibiotic which is given, it should be prolonged. So it is a very logical question. If the microorganism is resistant, why should we prolong the antibiotic? It is not needed. Then variability of the infectious process. Many infectious processes are variable, and the therapy can be extrapolated from one infection to the other. Means the duration of the therapy may vary according to the infection. So we can say that the duration of the therapy depends upon the clinical improvement of the disease and remission of the infection. If the clinical experience and the nature of the infection, they dictate that it is anticipated course, it will be 3 days, then 3 days of antibiotic therapy is enough. If 5 days, then 5 days of therapy should be given. As a rule of thumb, according to this, antibiotic coverage should last for at least 48 hours after the complete remission of the clinical symptoms. Means if the person is having clinically asymptomatic condition after the disease, at least 48 hours should be given for the therapy to continue. The treatment of usually the oral infections which are of bacterial origin, it will require an average of 5 to 7 days. Effectiveness of the antibiotics. It will depend upon the age, type, and the extent of the infection. Age means the elderly will be requiring the antibiotic therapy where the resistance has reduced, or the age of the infection. We can say that if the older infection is there which is slow in growth and well established, there also the bactericidal and bacteriostatic antibiotics both will be less effective than in newer infections. The type of infection means the larger the size and extent of the infection will be having lesser effect from the antibiotics, because they will have more and more of the virulent microorganisms. So higher concentration of the antibiotic will be required at the site. Then resistance of the drug, it can be due to many factors by which the resistance may be acquired by the microorganisms. It can be due to decreased permeability of the drug, inactivation of the drug, alteration of the drug receptor, alternative metabolic pathways which are utilized by the bacteria, then increased elimination of the drug from the body, and mutation also will help in creating resistance. Then patient compliance. It is also very important for the patient to comply to the dosage regime which has been created for that or customized for that patient. If the patient miss the dose or stop the therapy as soon as they feel well, it will be forfeiting the effect or the efficiency of the drug which has been predicted when it is planned for that patient and the infection. Now, the concentration of the antibiotic at the site of infection, to be very effective, the antibiotic must reach the site of infection in the amount which is above the minimal inhibitory concentration of the infective microorganism. MIC, as we say, it can be the lowest concentration which is needed to inhibit the visible growth of microorganisms in a media on a petri dish in the lab. Then metabolites and excretion of the antibiotics. The excretion of the antibiotics and the metabolism is in total called as the biotransformation. Every drug which is taken into the body undergoes a biotransformation either in the liver or the kidneys. So we expect that all the drugs will undergo some type of metabolic degradation by enzymes. Either they will be spontaneous change into other substances, or they can be excreted as such or unchanged. So we can say that penicillins, cephalosporins, aminoglycosides, polymyxins, they are mainly excreted to the kidneys, and various other antibiotics undergo varying degrees of biotransformation in the liver. So um, what are the indications where we can give the antibiotics? They can be given either in the therapeutic role, or they can be given as a prophylactic role. In therapeutic aspect, when we give the antibiotics, the patient's host response is decreased by diseases like diabetes mellitus, immunoglobulin deficiency, and malnutrition and alcoholism, where we have to give antibiotics prior to the infections. Then when treating the infections, and in cases of acute rapidly spreading infections, we have to give antibiotics. In cases of oral diseases like pericornitis, osteomyelitis, fracture of the bones, soft tissue wounds, infected wounds which are present, and the odontogenic infections which are there, which are spreading, so they have to be treated with antibiotics. The prophylactic role of the antibiotics is more than one third of the percentages when we are using antibiotics. For the post-operative wound infection, we give it prophylactically. In the prevention of endocarditis in high-risk patients who are undergoing any dental procedures, when they're likely to cause any bacteremia, so we give prophylactic antibiotics in such cases. Now, to sum up this topic or this part of the topic, we can say that a chemotherapeutic agent which has been used, or antibiotic, it can be bactericidal or bacteriostatic, and it will be acting on the cell wall, cytoplasmic membrane, ribosomes, RNA molecules involved in the transcription of genetic information, and it is given, the antibiotics have been classified in various aspects depending upon their features, and the routes of drug administration have to be taken care of when we are giving the antibiotic depending upon the bioavailability of the drug. Then dosage principles have to be done by clinical judgment. Duration of the antibiotic therapy, it has to again be decided by the clinical judgment of the case and customized. Effectiveness of the antibiotic therapy also depends upon the patient as well as the doctor who is treating the disease, and to indicate the antibiotics are indicated for the various therapeutic and the prophylactic roles. Any queries can be taken up on my email ID. Thank you so much.